Okay, good morning, everyone, or whatever time of day it may be if you're in a different time zone than we are. I'm glad to introduce Prakash Jayakumar today. I've been familiar with his work for quite some time, and so we're really glad to have him here with us. Just a little bit about his background. He is an assistant professor and director of clinical research and outcome measurement in the Department of Surgery and Perioperative Care at Dell Medical School at the University of Texas at Austin. And prior to that, he was an orthopedic surgeon at the Percival Pott Orthopedic Program in London. He completed fellowships in orthopedic trauma and upper extremity surgery in the UK, Austria, Switzerland, and the US. So very widespread knowledge and experience in different health systems. He has worked at the Harvard Medical School and Mass General Hospital studying principles of health outcome measurement, and completed a PhD at the University of Oxford in outcome measurement. He is a prior UK Harkness Fellow in Healthcare Policy and Practice Innovation. So he's really an international expert on the topic of health policy, particularly as it relates to musculoskeletal conditions and orthopedics. And so we're really glad to have him here to talk with us today.
Awesome. Thank you so much. Really appreciate the opportunity. It's fantastic to finally get a chance to speak to you guys. I've also been following how you guys are doing in terms of your work, and excited to hear more. Just give us a thumbs up if you can see the screen.
We can.
Great. Yeah, again, it's great to be talking to an interdisciplinary audience here about ways patient-generated health data can really accelerate value for our teams, patients, and care delivery. Thank you so much for the introduction. I should also say that I'm a visiting professor at the other institution down the road, and it's great to see one or two of my colleagues joining in. So I'll be giving a shout out to them during the course of the presentation. So in this talk, I really hope to walk you through my experiences as a surgeon, having recognized fairly early on in my training the importance of delivering care that goes beyond mastering technical elements of what we know and love as orthopedic surgeons and fixing things, to considering the whole person. And I suppose my experiences as scientists recognize the value of innovative tools that capture patient-generated health data to help us better measure and understand aspects of health from the patient's perspective and how they navigate their way through the healthcare ecosystem. Yeah, as Council said, of course, please feel free to drop questions in the chat function, but I'll try and address all of them as best I can towards the end of the talk. So I pose to you the first question: why are we measuring patient-generated health data? Well, I think the vast array of functions of patient-generated health data we all know, and I suppose we could kind of really brainstorm and get a long and distinguished list of functions. But really boiling down to it, I think there's three critical elements here that form a bit of a value chain for patient-generated health data. They allow us to prepare and understand the patient's story, in essence, and identify modifiable factors that influence health-related outcomes. They also allow us to perform and enable decision support and optimize shared decision-making. And thirdly, they allow us to perfect, to track health outcomes for improving care delivery in our health systems. At the heart of what we're trying to do, of course, is trying to achieve better understanding of the patient's story, their healthcare journey and the factors. So as I said, especially the modifiable ones, the things that we can do something about that might influence their health outcomes along their health trajectory, this dynamic change in health and illness over time. And I think most of us recognize that we're clearly in the midst of a paradigm shift from the biomedical model of care that's really focused on management of objective pathophysiology toward more of a biopsychosocial model that centers and caters around the physical as well as the emotional health and social well-being of our individuals that we're managing. This is clear when you see, when I've seen the elderly patients suffering hip fractures with a range of social issues, or the psychological concerns amongst adolescents and adult patients with a range of musculoskeletal derangements and degeneration and trauma related to their bones and joints. While much of the shift towards the biopsychosocial model has really been kind of led, and the charge has been led by the field of health services research, clinical clinical practice is, as I'm witnessing it, clearly catching up, and both patient-generated health data and technology are accelerating this transformation. So now I pose the question, what are we measuring? Well, diving a little bit deeper, it's important to ask what we're really measuring in terms of this biopsychosocial model. And I found it useful to anchor this around the World Health Organization International Classification for Disability, Functioning, and Health, which really conceptualizes health as a multidimensional construct that involves this dynamic interaction between impairment or objective pathophysiology, activity limitations and participation restrictions, and contextual factors, factors that are such as the environmental and personal factors. Now, even the World Health Organization have admitted that this kind of contextual factors component is somewhat nebulous, and they purposefully and intentionally don't specify the specifics around what those environmental and personal factors are, which allows us a little bit of dynamic fluidity to play when we try and anchor our patient-generated health data towards that model. I've spent some time describing that model, and you'll see in a minute that'll keep popping up throughout the talk, and you'll get a sense of why I've done it. So next is the question, how are we going to measure? And of course, it's important to appreciate that there's a lot of enabling tools here for capturing patient-generated health data. And broadly speaking, PRO measures or patient-reported outcome measures are the current gold standard tool for getting these snapshots of health and give our patients a voice here. But then they can be subcategorized into different ways. Patient-reported outcome measures that capture physical health, psychological health, social well-being, and quality of life. Patient-reported experience measures capturing aspects of our services, but also aspects that we're really interested in around care, such as trust, relationship, empathy. And patient engagement measures, this somewhat newer measures around capturing activation, grit, or self-efficacy. And shared decision-making, increasing kind of interest in shared decision-making also has a gamut of measures behind it. That capture decision quality, components such as decision conflict and decision regret, and control preferences, and all geared towards delivering a range of functions. Exploring the trends in outcome measurements and patient-generated health data in the form of PROMs in orthopedic trauma, there's certainly been a gradual transition from clinician-based outcome measures towards patient-reported outcomes. You can see the kind of dark orange line as an initial foray in the excitement in patient-reported outcomes, but not really much going in the way of psychometric evaluation, towards this lighter orange line, which basically shows the kind of explosion, certainly towards the early 2000s, around appropriately psychometrically validated patient-reported outcome measures. And I envision there's a similar trend probably when you look at other aspects of musculoskeletal conditions, you see a similar kind of graph. So my PhD and my initial kind of major step really in the direction of understanding the patient story was really anchored in this study that looked at arm fractures. So we examined 775 patients, and you can see the World Health Organization model there, patients with shoulder fractures, elbow fractures, and wrist fractures. And we captured a gamut of impairment factors, X-ray classifications, injury, energy, open, closed injury, surgery, etc. And really mapped the rest of it. So activity limitations, participation restrictions with an array of PROMs, looking at region-specific limitations, quick dash, for example, looking at anatomy-specific limitations. So PRW is a wrist measure, Oxford Shoulder Score, elbow score, and also measures of quality of life, EQ5D3L. In terms of their contextual factors, what I said, the environmental and personal factors, we're able to use a range of computer adaptive tests to measure psychological distress, depression, anxiety, also measuring activation, self-efficacy, and also some elements of social factors, promise, instrumental support, and emotional support that you can see there, and some other demographic details alluding to the patient's environment. So we longitudinally assess these outcomes from within a week of injury, around 2 to 4 weeks, and at 6 to 9 months after injury. and really tried to look at using bivariate analysis and multivariate regression. What are the dominant influential factors here? And it was somewhat surprising, but also kind of somewhat intuitive to see that, you know, the most dominant influences of outcomes seem to be factors associated with psychosocial factors and the use of antidepressants, the use of opioids. And interestingly, at 2 to 4 weeks, self-efficacy was the most dominant influential factor beyond impairment factors, radiological severity, injury gradings, things like that, as the most dominant influential factors of outcomes. So in summary, the negative coping, antidepressant use, and opioid use at less than 1 week, and pain self-efficacy, this kind of sense of grit or coping ability or resilience in the face of pain at 2 to 4 weeks, were the most dominant predictors of limitations at 6 to 9 months after fractures of the arm. Similar findings existed throughout, actually. So we did wrist fractures, elbow fractures, and proximal humerus fractures. And there were a variety of psychological factors that also played a role: depression, anxiety, kinesiophobia, the fear of movement, instrumental support. And also, we found the similar findings, again, in terms of the relationship in quantifying whichever PROM you use to measure limitations and quality of life. So looking at this in another way, we use the same cohort, but we also examined factors associated with both limitations and patient experience after these arm fractures. And we used something called factor analysis to load to see if there were different ways that these factors loaded or grouped together to express a common underlying factor or superdomains. And again, the groupings were interesting. There were 4 groupings: factor 1, psychosocial factors and engagement; factor 2, socio-demographic factors and engagement; factor 3, social factors; and factor 4, injury and physical performance. So these are obviously our own labels, but you can see the sub instruments that are grouped here on the left, channeling into what we termed into each of these factors. So we could get into some of the statistical issues around multicollinearity as a phenomenon where clearly to get a true understanding of the interrelations between these variables, we accounted for multicollinearity as best as we could. We also use correlation matrices and techniques to try and iron out multicollinearity and really kind of get at what were the factors that the kind of integrity of each of these factors in what we did next, which was multivariable regression. So when we place each of those factors, just so as a reminder, you can see the columns on the left, factor 1 to 4, on the left, what we labeled them as. It was, again, pretty interesting to see that the most dominant predictors of outcomes in terms of limitations measured by quick dash and promise upper extremity physical function, as well as patient experience with their clinical care and experiences of their health service, was factor 1, psychosocial factors and engagement. And you could see as well that the adjusted R-squared gives you an indication of how strong these models are. So we were quite confident that, you know, we were dealing with models that had a decent amount of strength and that we can make these assumptions. So again, in summary, psychosocial factors, psychological factors, and patient engagement seem to share a common underlying trait, and they also seem to be the most dominant predictors of limitations and outcomes, patient experience at 6 to 9 months after these injuries. And really indicated to us that, you know, for me, front and center, that the whole person fracture care really depends on accounting for these variables. Switching tracks to degenerative joint disease, we more recently were involved in a study that looked at factors associated with patient perceptions of osteoarthritis symptoms and also limitations following hip and knee osteoarthritis. So in a somewhat smaller cohort, we performed a study to look at the factors associated with these variables. And it was really interesting that misinterpretation of osteoarthritis symptoms was common. We measured how One of the variables being perception of the injury, perception of osteoarthritis as an injury versus something that is a normal part of aging. We also assessed what factors were influencing outcomes longitudinally. And again, psychosocial factors seem to have a greatest influence on limitations than objective pathophysiology as measured by KL grade. So where to next? Well, clearly, what I've shown you so far is just one drop in the ocean of a variety of studies that have shown that psychosocial factors play a dominant role in both limitations and patient experiences in a variety of musculoskeletal conditions. But looking at how we could better understand and organize ourselves around which factors dominate, I more recently been involved in studies with colleagues at Duke who have developed and utilized a multi-dimensional tool called the Osprey Yellow Flags. So this is an interesting tool which effectively assesses 11 general and pain-related psychological distress constructs to allow a more, I suppose, complete assessment of different psychological factors. So the super domains, I suppose you could class them as negative mood, fear avoidance, positive affect, and coping. But really, the idea is that it's a comprehensive screening tool assessment that is aligned with each of these prompts. So using a fewer set of items and through some clever validation and linking, there's a degree of sensitivity and specificity for these full-length PROM scores using the screening tool. So in a study by one of my colleagues, Trevor Lentz, and others who might have joined, sorry, I can't see everyone, but we asked the question, what common psychological phenotypes exist in patients with hip and knee osteoarthritis? And we had the benefit of two fairly large cohorts, one being the comprehensive hip and knee osteoarthritis care program cohort from the Joint Health Program at Duke with over 1,000 patients, and what we call the Osprey cohort. The Osprey cohort was the original cohort used that included patients who were non-operatively managed for knee, shoulder, low back, and neck pain. And using, again, factor analysis, types of factor analysis, and specifically latent class analysis, we identified 4 psychological distress phenotypes. So low distress, high distress, low self-efficacy, and negative pain coping. So diving into that a little bit more, distress, general psychological distress includes things like depression, anxiety. But interestingly, the Osprey certainly provides us this additional granularity to identify aspects of negative pain coping, things like catastrophizing, kinesiophobia, as well as low self-efficacy, so using the pain self-efficacy measure to capture those patients. So the low self-efficacy and acceptance are really those patients with low confidence in managing pain and their willingness to even accept the pain. Whereas the negative pain coping are the individuals that exhibit poor pain coping skills in general. So interestingly, we found identified these 4 distress phenotypes, but then took that forward in trying to assess what the relationships are between these phenotypes and limitations. So again, using a consecutive series of over 1,500 patients from the Joint Health Program, captured between October 2017 and December 2020, we did a comprehensive kind of assessment of those patients. So just pause there a little bit around the Joint Health Program. Clearly, I've shown you one kind of element of the program, the assessment of patient-reported outcomes, but diving a little bit deeper, the Joint Health Program is somewhat unique in that it provides a comprehensive osteoarthritis management approach that provides physical therapy, self-management of patients, structured exercise programs, sleep hygiene and coaching, and most importantly, psychologically informed PT, which includes cognitive behavioral therapy-based strategies. nutrition and lifestyle coaching, as well as all tailored to the patient's needs. And I can see Morven has joined here, has been the one of the founders and real developers of the program. So I'd love to discuss, bring her into part of the discussion later on. But essentially this multi-skilled physical therapist-led program was able to deliver a variety of these modalities and also created a backdrop for this study and the understanding the association with these conditions. So it's not just collect the measures, but watch, but also really patients who are engaged with the program and provided a variety of behavioral health strategies here. So again, interesting to see that, so I put this up as the final regression model, but I want to take you through a little bit of a walk through the process that we used here. So using exploratory factor analysis, we yielded two main phenotypes. I know I talked to you about four before, but we've kind of regrouped these individuals into two main phenotypes. One being fear avoidance and negative pain coping, what we call misconceptions. And general psychological distress is just mentioned here as the F2 distress, capturing depression and anxiety. And through multivariable regression models, separate regression models that assessed misconceptions and a variety of other factors, and then distress and a variety of other factors, both models show that misconceptions and distress in separate models were the most dominant influences of limitations, or associations, most dominantly associated with limitations. Now, when you grouped both misconceptions and distress together, interestingly, distress seems to have been kicked out. So this suggested to us that fear avoidance and negative pain coping, or misconceptions, seem to be the most dominant influential factors associated with baseline limitations. So this gave us a sense that first, there's heterogeneity within psychological distress. Can't just kind of group everyone in one type of psychological distress and say, you know, let's just deal with it. But actually underneath it all, there is this nuance of different forms of distress playing an important role in how they impact outcomes. And therefore, additional focus should be on strategies to identify and manage these different types of distress in different ways. And I'll show you some of that towards the end in terms of care delivery. But for now, leave you with managing misconceptions, for example, using cognitive behavioral therapy techniques, pain coping skills, relaxation training, amongst the many myriad of strategies available, but thinking about it as not just one entity here. Similarly, we did another study with the same cohort and now looked at different combinations of distress and misconceptions. And not surprisingly, you can see that high distress and high misconceptions seems to have the most dominant influence out of the lot in terms of the association with limitations, this time at 6 months. So these are factors associated with limitations further down the line. But again, you can see that there are different combinations that warrant probably different strategies and tailored strategies to each of those different phenotypes. So just to close that off, high distress, fear avoidance, and negative pain coping were all dominantly associated with 6-month functional outcomes. So that was a kind of a whirlwind through the data supporting psychological factors and their influence on outcomes. But clearly, we often bandy together psychosocial factors together. And while I dipped my toes in the water looking at emotional support and instrumental support, really the holy grail is to somehow look at ways to incorporate the social determinants of health, which we know are critically important, especially considering the state of healthcare today in light of the global pandemic and issues around equity and inequality in modern healthcare that clearly have to have an impact on outcomes. So again, drilling down a little bit more, you can see the wide variety of different factors. Again, we're talking about heterogeneity and psychological factors, but if you look at this from the social determinants of health perspective, there are a variety of different elements to each of those 6 social health domains that have an impact on health and well-being. So how we've taken our initial shot at looking at this is trying to capture just firstly the associations between what we would how we might quantify unmet social needs, and understanding what the association between these social needs is with limitations in patients with hip and knee osteoarthritis. So in our analysis of 173 patients, using something you can read the abbreviation there, but it essentially is the Accountable Health Communities Health-Related Social Needs Survey, which assesses essentially 5 domains: housing, food, transportation, utilities, and interpersonal violence. And using this tool along with a range of prompts, we conducted bivariate analysis and multivariable regression, which essentially demonstrated that the greater numbers of unmet social needs, as assessed by the survey, and being unemployed were the most dominant factors, associated with lower levels of limitations and poorer mental health. So our opening salvo in this kind of a dip into social factors and how we might incorporate those has been through using this type of validated survey. And we are planning to incorporate social factors using that survey almost more routinely in our research, but also potentially as a standard of care. So just to round this kind of initial third of the talk out, essentially, I've shown you a variety of different ways of approaching the question, but really outcomes that matter to patients certainly seem to be strongly influenced by emotional health, social well-being, and patient engagement and experience as much, if not more, than pathophysiology. Now, this is not to ignore pathophysiology, of course. I certainly had a real grilling from my assessors during my PhD viva around that. But really, when you group it all together and you're doing more and more sophisticated analysis, it seems that psychological factors accounting for all of the multicollinearity and other statistical issues still seem to come up head and shoulders above objective pathophysiology. So moving to, I might pause there actually, because I've done a lot of talking, and just if there's any initial questions, please do fire away. There's nothing in the chat I can see at the moment, but I'll pause for a bit and see if there's any reflection on that before I go on to decision support and shared decision making.
PJ, I'll ask you one question on that topic. As you were talking particularly about the first set of results on arm trauma, I was just wondering, from your perspective as a clinician and seeing some of these psychological factors, I think in that it was mostly self-efficacy, but you've talked about other ones as well.
Yeah.
I'm just curious, there seems to be consistency across the results you're showing with respect to the importance of psychological factors. How do you see this play out? I mean, these are constructs we can measure. Since you have a lot of experience both on the research side and also on the clinical side, can you give an example? And I'm asking this because I think this gets to like, what do we do next?
Yeah.
How do you see these kinds of psychological factors at play?
Yeah, and it's a great question and almost a segue into the next section. But briefly, I think we're now beyond the kind of right. We appreciate that these are important, but what do the how to kind of apply these? I think firstly, I think we're now at a stage, and as I've shown you with some of the phenotype work, at really stratifying or grouping these patients in a more intelligent way. I think that's critical at the get-go to say, well, whatever psychological measure you use, could it fulfill the function of stratifying the patient in a way in which I could then help define care delivery? So I'll show you an example at the end. So I'll half answer your question now and I'll get to the end. But the Joint Health Program have done a very, very interesting exercise, and Morven can allude to this as well, around, right, we've taken this information, but how does that play out into clinical practice? And so they've created care pathway roadmaps based on the phenotypes that have been defined by defined by the PROs. And in a similar way, I think in orthopedic trauma and whatever condition, you can do the same thing. And so I think as long as the tool allows you to do that, it doesn't have to be the OSPRO. You can still capture critical psychological constructs. For example, I mean, we use PHQ-2 and 9, GAD-2 and 7, and pain self-efficacy in our care delivery model. I mean, ours is persistently painful conditions that we manage. But again, in trauma, there's no reason why you can't capture those at baseline, and then stratify the patients accordingly, and then say, well, and the work, by the way, at Oxford led on to some of this, was to have in-house behavioral health specialists, for example, those that are sit in within multi-vehicle accident, polytrauma patients, UK terminology, that often present with a lot of these psychological concerns. And so, immediately the orthopedic surgeon is not just seeing a patient in fracture clinic as a one shot and going, well, I can see that there's something going on here during my clinical acumen, or using patient reported outcome measures, and then referring the patient on. And then you kind of had issues with coordination and continuity of care there. And so I think that's a critical element, to have something on the front face and build your care delivery model around the measurement. So I will finish off the answer to that question with an illustration at the end. That's okay.
That's great. Thank you.
So again, anchored in your question is also what we do, right? And so in terms of performing, we enable decision support and optimize shared decision-making using patient-generated health data. So baseline here is say, well, we measured, right? What can we do? And so, I mean, this is a 2015 paper by Berliner et al. and the chair of department here at Dell Medical School, Kevin Bozek, where the patient-reported outcome measures, as measured by the KOOS scores, can also be an initial indicator, as long as you take the patient picture into account, indicator of the likelihood of the potential benefit that the patient might receive from treatment. So the graph really shows KOOS score predicting likelihood of benefit following TKR. You see that dotted vertical line that basically where the benefit, the MCID, minimal clinical important difference, the threshold there of 58, signaling that complete nosedive. And so the way that plays out in clinic is say, well, taking the whole picture of the patient into account and their KOOS score of 58, should I really be operating on the patient if their KOOS score is above 58? When they're telling me that they can achieve, a certain degree of physical function and capability in doing what they know and love, right? And so that's one way of looking at it. Now, we've talked a lot about psychological factors and mental health. Now, when you layer mental health onto the physical function scores captured by KOOS, you can see the variable influence of psychological factors along the way. And again, each little hexagon kind of represents MCID or likelihood of achieving clinical improvement. And so you can see that the mental health has a clear influence on impacting the KOOS score, the level of function that someone can achieve. So it's just an indicator that is important to consider here. So moving on to that's what you can do with the PROs statically. Shared decision-making is more of a dynamic approach to looking at how patient or opening the door for how patient outcomes data can enhance shared decision-making, which really is defined into these domains of knowledge transfer, expert communication, and defining the goals, defining the preferences, values, and needs that are required to inform treatment outcomes. A study that that I wanted to just tell you about now, taking that into account, that sounds like a great definition, and it's what we would all aspire to. But really, here we ask the question: how aligned are patients and surgeons' ratings of how they perceive their involvement in decision making? So this study of 136 patients with hip and knee OA, where we looked at the control preferences scale and modified control preferences scale that surgeons answered was interesting. We basically observed that surgeons really misperceive patient participation decision-making. They might be thinking that patients are well and truly participating in the decision-making process, but that's certainly not what patients are telling us. So that was really just the quick short summary of that study. But this misperception really signals the need for strategies to enhance participation of patients, but more importantly, understanding not just participation, but understanding their preferences, values, and needs. And so our approach at Dell Medical School in terms of shared decision-making and how we approach it through tools and patient decision aids is a partnership between us and a company that has really enabled us to approach this in a technology-enabled way. So there's three components to this patient decision aid that we've been working on: an education module, a preferences module, and an outcomes module, what we call education, preferences, and forecasting as the three components. So walking you through that, patients come in, knee osteoarthritis patients specifically, they check in, they complete their proms at intake, and then they are given an iPad or paper if they wish, based on their preference, where they can learn about osteoarthritis. They can understand the different treatment options and the pros and cons of each, and do a knowledge test at the end to see if they've actually captured some of the teachings. They also rate their preferences. I'm going to show you a little bit of detail about this later. But in the background, the prompts they completed, along with a variety of other data sets, data points, provide a personalized benefit risk report, and the decision is conveniently reached. Now, drilling down a little bit more, I've told you about the patient education. There's nothing more to really say about that. But the next two components are we found extremely interesting. Preferences elicitation is done through these sliding scales that really try to capture patients' level of preference around pain relief, around recovery time and how much time they would invest to recovery periods. And also in terms of the willingness to take on risks of surgery. So getting a little bit into the nuance of that decision-making process, and to a little bit of nudging and helping them along the way is with their surgeon having these dynamic visualizations of risk where you can slide up and down things like weight, symptom intensity, and limitations that also give you the level of benefit that you might receive. Now, I've gone through that, but really the kind of brains and behind this, when I've said technology enabled, it's really artificial intelligence enabled forecasting and specifically machine learning. So the company have access to a large national data set with hundreds of thousands of data points and have created an algorithm, including PRO data, that's allowing us to throw in our patients' demographic details, clinical factors, patient-reported outcome measures, and utilization metrics to generate the likelihood of benefit for patients like you or patients like them, the benefit of total knee replacement if we were to do it tomorrow, the risk of total knee replacement if we were to do it tomorrow, and the likelihood of their improvement in quality of life, stiffness, and pain. Now, this clearly takes the guesswork out of which often happens in the consultation. Through the best will in the world, you get data fed back to you and say, well, yes, I've operated on 1,000 patients over the last couple of years and my complication rate is this, but really that's pretty much it. Drilling down a little bit deeper, we get into the specifics around benefits, change, and risk of complications. And this is the report that the surgeon gets and the patient gets before shared decision-making consultations occur. So we managed to publish our data in a randomized controlled trial, looking at artificial intelligence-enabled patient decision aid, and compared this to just pure education only. So patients received the iPad with the education materials, but it stopped there, and then went on to have the surgical decision-making consultation with the surgeon. And we looked at elements of decision quality, level of shared decision-making, patient satisfaction, and limitations, which all improved with the patient decision aid. Now, the interesting piece of this was, which was a surprise to us, is like, well, the patient decision aid, we can understand decision quality, patient satisfaction, and even shared decision-making, the quality of the shared decision-making process, but the limitations seem to improve as well. We think underlying this is probably some degree of patient engagement driving improvement in limitations, having the tool, having the additional attention to the tool and the support that it provides ahead of the consultation. So that was interesting. We also addressed a number of other factors which are clearly also important, especially to orthopedic surgeons. Does it reduce my surgical rates, and does it reduce my the actual kind of concordance of what the patient decides and what they eventually go on to have? And also, quite pragmatically, does it increase my consultation time? And it didn't seem to have a difference in any of those parameters. So what's next for this tool? Well, this tool, and I think tools in general that use technology-enabled decision-making, and there's probably few out there at the moment, but really the idea is to have, if there's artificial intelligence driving this model, to have clinician training around the ethics and legal issues around the data points. Clearly, you're presenting a lot of sensitive, granular information to these patients. You want to convey the right amount of information to them, as well as knowing enough about the technology behind it that's creating the data, the specific data points, the personalized data points. We need to scale and test this. This has only been a first site, and so we're doing this, replicating this at a second site in San Antonio. Of course, when I say artificial intelligence, there's an asterisk there. It's not quite a learning solution yet, in that we haven't fed back into the decision-making algorithm our patients' data from Dell Medical School. So once that goes into repeated cycles of evaluation, the algorithm will get more and more refined. That's the idea, and give us more and more insights. So at the moment, trying to integrate and automate the process and making this a learning solution. And I say, policy and practice change. Washington State has introduced shared decision-making criteria for specific patient decision aids, and there might be, is likely to be a future kind of roadmap here for patient decision aids becoming part and parcel of practice and policy change in care delivery. So just looking, mindful of the time, I want to get to this stage, which again alludes to Kelly's initial question, about how are we going to make this kind of bring this to the real world. And so the last kind of third of this talk is around tracking and monitoring health outcomes for improving care delivery. And so where we are at Dell Medical School, we have the Musculoskeletal Institute, which has an integrated practice unit, which has essentially a value-based approach to care. We say condition-focused because we're not focused on the procedures and volume of procedures, but more around conditions. And in this case, an example will be osteoarthritis. Having a team-based approach to managing these patients and having a comprehensive 360-degree whole person care model. Now, that's not just lip service. We have, as you can see around the patient, a team-based approach where we have an advanced practice provider, social workers, care navigation, dietitian, and physical therapist, all working with the surgeon in a co-located single space in clinic, working literally across the desk from each other. There's no rooms in between these various clinicians. They work in a common space, and they all work together in a team-based approach to provide the range of services that you can see there, everything from structured exercise programs to behavioral therapy, and of course surgical care as well. So snapshots of those outcomes, and I'm happy to kind of dive into those models towards the end, but the snapshot of the outcomes are, we've shown improved medium to long-term functional outcomes in both IPU-based non-operative care alone, as well as IPU-based surgical care in the patients that we've seen since our birth in October 2017, as well as a substantial number of those patients, a high proportion of those patients achieving minimal clinical improvement and substantial clinical benefit. And interestingly, based on thresholds that have been that are from the literature, that have been designed using patients who have undergone surgical care. So MCID, minimal clinical important difference, and substantial clinical benefit. As you can see, high proportions of patients achieving those. Yeah, these are the non-surgical care patients, as I alluded to. So interestingly, I've had a great opportunity to work closely with Morgan, Malay, and other colleagues around another program, the Joint Health Program at Duke, which again has taken a slightly different approach to building a team that's still managing the condition, but this is physical therapist led, and the physical therapists work as primary osteoarthritis care providers closely with surgeons, again, providing a comprehensive approach to managing persistently painful musculoskeletal conditions. And through extensive skills training, and they're essentially multi-skilled providers working at the top of their license, providing a range of treatment strategies around the patient's needs. Again, the improvements in medium and long-term functional outcomes are also impressive with patients who undergo joint health program alone. So those are just non-operative strategies, as well as the patients that undergo joint health program plus surgical care. Now you can see these bars aren't largely different, which is really, really fascinating, that the patients, for as far as I can see, for one of the initial first time the data's come out around focused non-operative strategies in the United States, managing these patients comprehensively and achieving quite substantial outcomes that aren't far off surgical care. Again, significant proportions of patients achieving clinical outcomes in JHP plus surgery in the form of knee replacement for the NEOA patients, and JHP only. And getting to Kelly's point, what do we do? So one of the interesting components of the joint health program is the use of the OSPRO tool, which I showed you earlier, and those phenotypes, which I described earlier, the low distress, negative pain coping, low self-efficacy and acceptance, and high distress. And this is just for illustrative purposes only, and it's purposefully in small print because this is still being refined. But the idea is then, how might you create these kind of care pathways that are based on the patient-reported outcome measures, in this case, the number of yellow flags or clusters of domains that you've captured? How can you then design activity-focused strategies around that? How can you design your behavioral health-focused strategies? And finally, practical, brass tacks here, how can you give a guideline to your providers and clinicians around the number of visits and the duration in which this should occur? So I want to tail off with what next, right? What might we further advance? How might we further advance the utility and application of patient-generated health data, just to finish off? And this is a whole talk in itself, but to summarize the strategy, I look at it from the perspective of a patient-focused, technology-focused, tool-focused, and systems-focused. And I purposefully mention these things because there's still lots of work to do in each of these areas. From the patient focus, using a human-centered design approach that really trying to understand patients and how they interact with patient-generated health data, we've tried to archetype patients into different levels of engagement. Everyone from the proactive and engaged patient to those that are disengaged and overwhelmed, because we've got to cater. And reality is that there's a lot of different patients here, and we've got to really cater for all patients' needs. You don't need to read these comments, but really they're trying to get at the insights that we've gained from our design work around patients and health professionals really needing a better understanding of PROs and the utility of PROs. There's some element of better engagement that can be done here. Patient-reported outcomes only really come alive when they're placed in context of the care pathway, so patients can really understand why we're using them. We talk about patient-reported outcome measures in our care delivery model, like we talk about blood tests and X-rays, but we don't always treat them in the same way, in that we don't give that we capture these measures and the scores, but we don't always relay that information back to patients. The informed patient can really also then become partners more effectively become partners in that process and decide which scores they might want to see as well, guiding us towards better refinement of a PRO strategy. And then insight 4 it's always interesting to see from the patient's perspective along their pathway and reflect with their family and friends as part of the care team to bring them in. So our human-centered design work which is in play right now is trying to tweak the measures for better patient engagement through better framing and priming of questions, goal setting. So when I say framing and priming, patients, for example, can fill out a variety of different things. They're asked to do a variety of different things, from registration details to kind of very mundane things, and then flow straight into patient-reported outcome measurement. And again, don't really realize the difference. And although it sounds very simple, this can also be something that sparks disengagement from doing these questionnaires further down the line. So framing and priming is critical. Asking patients about their personal goals is also a bit of a part of framing and priming, in that you can then get a little bit more into the nuance of personalization and them feeling like these are important as part of their care and part of us understanding what matters to them. Visualizing the data and relaying the information, graphic design, all of those are different strategies, and even things like text messaging, auto reminders, and education as part and parcel of what probably needs to be a wraparound set of strategies to make this a success. In terms of tools, I'm not obviously going to, with the time, I'm not going to dive too much into this, but really snapshots here of quick strategies. You can keep that minimum PRO suite of measures to not avoid overburdening patients. Things like computer adaptive tests are very popular, and certainly reduce the time that can, both the efficiency, but also with the precision in which they capture PROs, maximizing the use of screening tools like the Osprey, for example, and designing new shorter PROs. We've gone through that process. We've tried to do it all. We want to get cats into our PROMS battery of tests, but also redesigned one of our surveys, which was really a patient kind of experience survey, but went through cycles of iteration to really capture what we think at Dell Medical School, a framework of capability, comfort, and calm, what really matters to individuals captured by the three C's. And this 7-item patient outcome survey is designed, again, through statistical techniques to have 7 questions that really try and get at this. So watch this space. It might be something that ends up replacing some of our PROMs down the line. The technology focus, I've touched on artificial intelligence, but really I want to tell you quickly about digital phenotyping and saying, well, might there be, I've talked a lot about PROs and patient-generated health data, but they still have their limitations. And so might we better capture passive patient-generated health data continuously over time with smartphones and wearables? This concept of digital phenotyping was coined by J.P. O'Neller at Harvard School of Public Health, who we're working with to try and define associations between the passively generated metrics from things like smartphones and wearables to PROs as an initial validation, and thereby potentially creating a hybrid where you might envision someone coming to clinic, signing them onto a smartphone platform. I'll just whiz through some of these. This is some work that's been done in breast cancer, but really smartphone platform that can capture a variety of different activity, behavioral, and communication metrics to also understand what patients might be experiencing when they're outside the 4 walls. So we're working on that as part of a grant as a next step towards a technology focus around patient-generated health data. And finally, zooming out here a little bit, quality improvement, of course, is essential. And I intentionally put this in. It's not just something to say, well, that's very nice, but really to intentionally ask the questions around what are we trying to accomplish around patient-generated health data? How will we know when there's a change in improvement, and change that will make a result in improvement? And we've set up a quality improvement strategy with a clinical leader, project sponsor, day-to-day leadership, and technical expertise. This is all borrowed from the IHI guideline for improvement to create a PROMS strategy and patient-generated health data strategy. And this is just a snapshot of some of the stuff that we end up doing. We've mapped the patient flow and the clinical team flow and the research team flow, and these red kind of problem hotspots come up periodically as we assess some of the issues. And it teaches us really that this is a dynamic beast. So I'm going to quickly get through this slide and then just open up for questions. I know there's only a few minutes left, but I'd leave you with this question of really trying to understand how mature your institution is at implementing and applying patient-generated health data. Where are you along this maturity model? And giving yourself a sense check on how you might create a strategy around patient-generated health data for both your clinical and research needs. We're right in the process of looking at this from the alternative payment model perspective. And there's a systems level impact here as well. So as an orthopedic surgeon, clearly passionate about patient-generated health data, I can't really not mention one of the godfathers here of patient-generated health data, the pioneering shoulder surgeon, Ernest Codman from Boston, who really revolutionized medical practice, safety, and quality of care in orthopedics through championing outcomes analysis. And he said, every hospital should really follow every patient it treats long enough to determine whether or not treatment has been successful, and then to inquire, if not, why not? I think this still stands so true after several decades. And I think we're in a position where we're much better at understanding patient perspectives, but in the realm of trying to take it to the next level and figuring out what to do with the data. So thank you very much. That was a bit of a whirlwind. Take any questions.
PJ, I'll ask one, and I don't want to dominate here since I've already asked one, but I will at least kick us off. You mentioned just a moment ago alternative payment models. I've been wondering all along your perspectives on costs and reimbursement and access for patients who are uninsured, underinsured. I'm just curious about just philosophically, or where you see things heading in terms of getting these integrated in the health systems, particularly with respect to costs of care.
Yeah, I think that's a fantastic question, and our approach, and I think seems to be playing out right now, is again starting off with a condition-focused approach to care that's heavily driven by outcomes that matter to patients. I mean, it rolls off our tongue at Dell Medical School, but really, yes, it is a huge lift. But trying to build in patient-generated health data at this point in time, it happens to be PROMS as the current gold standard, but building that into not just collection, but patient-reported outcome measures as performance metrics to really drive that care. And I think the idea is also, again, your point is well made around underserved populations. I mean, 50 to 55% of our patients are an underserved community that are on medical access program insurance that are vulnerable patients, essentially. And so we measure that outcomes, or shown that condition-focused approach to the payment through a bundle episode payment for all patients, and PROs as part of that, built in as part of that arrangement. And CMS and CMMI have a great opportunity here to set the benchmark here for everyone, really, and saying, well, this is how we're approaching the payment model and how we would cost it up. Now, in terms of the cost and also how we've approached it, we've tried to use micro costing approaches such as time-driven activity-based costing to really get at the true costs of care. And we're working on different ways of looking at value for the different types of phenotype of patients that come in, the high needs patients versus the kind of the more straightforward, clinically less complex patients, and looking at that in a much more granular way. And so using that type of approach with more traditional approaches like RVUs and other macro costing approaches to come to a cost for bundled approach to care that might hit the mark and achieve what we want around the next generation of payment models.
That's very helpful. Thank you.
Great. Well, it was a fantastic experience to talk to you all. Please do reach out. I'm happy to. I know there's a huge amount covered, so I'm happy to, connect and answer any other questions you might have.
Thank you, PJ. We will look forward to continued collaboration with you.
Sure. Thank you.
Thank you.
All the best.